We're going to move right on, and it's my distinct privilege to now introduce our next speaker. And that's Dr. Wesley Clark. You heard this morning my colleague Lynette Albright mention about the gratitude that we feel towards CSAT for their support throughout the years in both treatment provision to our individuals in our country, to the ATPCs, and to the recovery movements, and those in recovery, the summits, the symposiums. Themes from those symposiums are available if you want them. Ask at the desk. We were able to get them. You have in materials that are being passed out today. In their packet, you'll see distinct materials that are related from CSAT and SAMHSA to speak to the words, definitions, the emerging language. It really is quite an honor to introduce the one person who embodies the spirit of the Center for Substance Abuse Treatment and SAMHSA. I will not take the time to read his full credentials. We will be here all afternoon. Dr. Westley Clark.
Thanks, and I don't want to keep you here all afternoon. Looking around the room, I see so many people who have been actively involved in addressing the issue of recovery, who have been advocating for substance abuse treatment. So I feel we're quite humbled, and I don't think that what we can do at CSAT is going to be the definitive thing. But we needed the input of the community. We need the input of community actors and players who have already been working very hard to produce the concept of recovery. The first thing I'd like to do is to acknowledge the SAMHSA staff. The SAMHSA staff present here, Stan. Important thing for us to recognize, and then Ms. Copperfield, would you stand also, since you were previously a staff? I'm not trying to embarrass anyone, but I think that my staff has been working very aggressively with a lot of you over the past year, so that we have a good concept of what we should do and where we should go. We are in a period of transition, so this discussion becomes important in the context of a developmental discussion, as opposed to a branding discussion. It's a developmental discussion because, indeed, the Hatch Act prevents me from siding with any of the people who are running for president, but whoever becomes the president will have an influence on what it is that we do. So whatever it is that you do, perhaps that you can influence whatever it is that they do. The key issue is, if this issue is not on their minds, then a lot of what we do is going to not go away, but it will be impaired. The current president acknowledges the importance of substance use disorders in health care. He states that to build a future of quality health care, we must trust patients and doctors to make medical decisions, to empower them with better information and better options. And sort of a health care oriented paradigm, the president has often talked about recovery and substance use disorders. But the notion here is that we have to involve both those people affected by alcohol and drugs and those people who are working with those people who are affected by alcohol and drugs. Terry Klein, my immediate boss, states that at SAMHSA our mission includes helping prevention and treatment counselors, clinics, and healthcare providers develop ways to change their service system to increase positive outcomes for their clients. This notion of outcomes is something that we regard as very, very important at SAMHSA. No matter what model you use, what strategy, we need to be able to identify the results of our efforts. As most of you know, SAMHSA is one of the 11 grant-making agencies of Federal Health and Human Services with a $3 billion budget. I'm not going to dwell on that. We're concerned about science, not ideology and anecdote. We work very closely with NIH, we've got, we work with Nora Walkoff, we have Tim Tomlin here, and TK Lee, we've got Mark Olbring here with NIAAA. The key issue is that we want to make sure that what we are doing can be rooted in the scientific as well as the empirical. Most of you are familiar with our matrix, where our vision is a light in the community for everyone. And from a recovery-oriented perspective, of course, that means everyone. And our mission is building resilience and facilitating recovery. That word recovery has been with us for a while, and we need very much to, as we flesh it out from a substance use perspective, we also need to know that we're fleshing it out from a mental health perspective, a behavioral health perspective, a holistic perspective. We have 3 centers at SAMHSA, all addressing some aspect of the notion of recovery. What do we do? What do we talk about when we say recovery from a prevention perspective? What about a mental health perspective? And what about a substance abuse treatment perspective? We at SAMHSA are supporting a comprehensive approach to public health. In this model, we've got law enforcement should include child welfare, child protective services, substance abuse treatment, substance abuse prevention, and mental health. This Dr. Klein's focus is on an integrated view of public health, including substance abuse and mental health. We face multiple challenges: reaching those in need of services, providing adequate resources, developing culturally appropriate and evidence-based interventions, building and sustaining a qualified workforce, and integrating substance use disorder services in the public health paradigm. Resources becomes an issue. Whatever we talk about with regard to recovery, we have to ask questions about how are we going to pay for what it is that we do. There has been an increasing burden on the public sector. In 1986, there was a public sector, private sector split of 50%. By 2003, the public sector is picking up 77% of the cost of intervention. So whatever model we're talking about, we also have to deal with the issue of we've got a social attitude that the private sector's role is minimal. We need to be very much aware that indeed the public sector can only bear so much of the burden. And if we don't deal with that, then recovery then, in terms of a resource issue, is problematic. Now, we all know that there's a public health imperative. We all know there's a public health imperative with regard to substance use disorders. We know that it can lead to complications associated with a wide range of medical conditions, which we want to treat. We want to treat these conditions. Mike and I were talking about cigarette smoking. For years, we treated the consequences of cigarette smoking. In fact, even advocacy groups benefited from the consequences of cigarette smoking. Lung cancer, so we focus on cancer. Lung disease was aided by all those people who got lung cancer from cigarette smoking. We didn't focus on cigarette smoking, we focused on the consequences of cigarette smoking. Lung disease, all these other diseases associated with it. We have to deal with the fact that substance use disorders affect brain disease, they affect children, result in dependency, associated with homelessness, criminal justice, gambling was mentioned earlier, a whole host of issues, and including bad teeth. We need to keep that in mind. HIV, suicide attempts, suicide disorders, they're public health issues. We know that we, as a society, we promote alcohol use. We have some 57 million binge drinkers. We know binge drinking is associated with a wide range of problems, driving under the influence, automobile accidents, and then we have some 17 million heavy drinkers. We know that substance use and the drug use in the general population is going down, but we still have problems with drug dependence. When we do those sub-state estimates, we have different concentrations in different populations, different states. We have a problem with non-medical use of pain relievers. What we need is a constituency. Alcohol dependence. I was just in Montana. Question that the people in the great state of Montana wonder, why us? We can't answer that question. at the federal level. It is a community problem, just as recovery is a community phenomenon. The challenge remains. We have a condition where the perceived need is small. When we look at our household survey data, and many of you have seen my great red slice, the waiting list is 314,000 people. 314,000 people perceive the need for treatment but cannot get it. 314,000 people. But we have 21.1 million people needing treatment but not receiving treatment, so you can subtract out that 314,000 people. And you still have a large number of people, 95.5, 20 million people perceive no need for treatment or recovery. Now, think about that. When we talk about demand for services, demand for resources, if 20 million people said, hey, we need to reallocate our society's resources to deal with our problems, versus 314,000 people saying nationwide, we need to reallocate society's resources to deal with our problems, what kind of response do you get? 20 million people say we have a problem. The insurers would be a little more attentive. The employers would be a little more attentive. The unions would be a little more attentive. And perhaps we would have a much larger community. So it's important, and it was good to hear that in Philadelphia, 1,000 people got together and said, hey, we are in recovery. And that 1,000 people can convey a message to the community, to the faith community, to local politicians, to national politicians. These voices need to be heard because we have a problem that's understated. Few people are moved by the muted voice. Dollars are scarce. We have an economy that is currently suffering. The muted voices are whispers. We need more than whispers. I pointed out the public health consequences. Bertha Madras from ONDCP often points those out. Tom and his collaborators have often pointed those things out. But those voices are heard by the 314,000 people, not the 20 million people who endorse DSM-4 criteria for having problems associated with alcohol and drugs. Psychosocial, detrimental function. As a result of alcohol and drugs, do you have a problem with your job? Yes. As a result of alcohol and drugs, do you have a problem with the law? Yes. Do you have a problem with your health? Yes. A problem with your mental health? Yes. Do you need treatment? No. So if I'm this bean counter, trying to figure out where do I allocate the limited dollars that I have, that no is reassuring. It means I don't have to spend any money over there. And that's part of the issue. We don't have to spend any money over there. We need to understand that we have different treatment strategies that are defined by the big red slice. When family and friends, employers and co-workers deny that there is an issue, then the treatment strategies and the resources, these are some of the options that are available to us at SAM, so these things are diminished. And if you don't get the kind of response that you need to put us on that inventory of critical issues. We are trying to shift the paradigm, recovery-oriented systems of care. We want recovery from alcohol and drug problems to be viewed as a process of change through which an individual achieves abstinence and improves health, wellness, and quality of life. Our recovery-oriented systems of care shifts the question from how do we get the client into treatment, as was pointed out, to how do we support the process of recovery within the person's environment. But we need to be careful. I'm from the government, I'm here to help. I can't help you if I don't have a legitimate role. Basically, our role is to help bring resources and to give venues for the discussion. If it's too much of a cultural phenomenon, a social phenomenon, as a public health representative, I have little role. Meanwhile, the bean counters, oh, you don't have a role. Not a problem. Move this money to other things. What about MRI machines? I understand we have a new bona fide MRI machine. In the previous administration, we had this episode where we were trying to decide in the waning hours of the administration whether we were going to get rid of the IMD exclusion or buy PET scanners. They chose to buy PET scanners. So why are you buying the PET scanners? Well, because they look like they might have some use in the future. Say, what about getting rid of the IMD exclusion? Well, you know, it's a controversial issue. Let's think about it. But they continue to think about it. We're still thinking about it. But we have PET scanners. I read the newspapers. What are the clinical indications for PET scanners? Well, we're not quite sure. How much do they cost? A lot of money. Each PET scanner costs a lot of money. So the bean counters said, well, you know, we'll do that. Tom Kirk. Kirk's been mentioned a number of times by a number of people, and one of the reasons he's been mentioned is in fact because he's thought about this issue. The traditional course of treatment for substance use disorder includes intervention by the public sector, the insurers, the professionals. When symptoms are acute, when symptoms remit, person's discharged, we say bye. You run a 28-day program, on day 29, what do? Nothing. You run an intensive outpatient program during the time that you're not having any contact with the person. Who has contact with the person? You don't know. So Kirk argues that we have an acute symptomatic system that is discontinuous in its orientation and crisis management in its focus. And we needed to promote self-care, rehabilitation during those interim periods. Then we can actually normalize a person's experience by moving a person into a recovery zone, by acknowledging that in fact slips can happen, but you don't have the harm that occurs when you have this wide swings in a person's experience. And those wide swings are very, very important to us here when we talk about recovery, because those wide swings are associated with harm. It's important for us to keep in mind. The larger community is concerned about harm. Some of you have heard me use my anecdote. I'm walking down the street, minding my own business, not bothering anybody, nobody's bothering me. I got money in my pocket. I'm feeling okay as an old man. Somebody strung out on alcohol or drugs spots me, decides I'm an easy mark, runs up, knocks me down, takes my $20 out of my wallet, and runs down the street. It's a hapless soul, a little disoriented from the methamphetamine, strung out on the cocaine, and drunk as a skunk. Gets caught, is sent to jail for 5 to 10 years. I get up, I got a bad back and no teeth. 6 months later, I got a bad back and dental implants. A year later, I got a bad back on prescription drugs and dental implants. If you want to help me, keep that person from hitting me in the first place. That's the solution. But nobody wants to treat that person because we have 314,000 of those individuals. We're trying to speak to a problem that 20 million other individuals have but who are silent. And who, in a community where silence is tolerated. We know that most clients undergo 3 to 4 episodes of care, and that's what Kurt's model addresses. We normalize that person's episode, we diminish the amount of harm, and you get a larger response from the larger community at large because we minimize the harm. When you read the newspaper, child welfare says, look, we don't want dead babies. We don't really care about recovery. We care about dead babies. Open the newspaper, you got a dead baby, it's associated with drugs and alcohol, the society rises up. We want to smite the offender. We need to be able to promote those voices so that when the bean counter is allocating the resources, they allocate resources commensurate with the problem, We need an integrated, collaborative model that optimizes recovery outcomes and improves cost effectiveness. So part of what we're trying to do, this is a draft that I'm going to talk about, is work with you to define a publicly oriented or a organized-oriented, recovery-oriented systems of care approach. Treatment agency is only one of the many resources, not unimportant, not too important. We want to reintegrate that person into the community. No one source of support is more dominant than the other because there are many pathways to recovery. Johnny just got up here. You gave him an award. And what did he say about his recovery? Johnny, did you go to treatment? He said no. There are many pathways to recovery. The fact that he didn't is not the issue. Some people do have to go. Various supports are needed to work for a person to recover. The client needs to play a major role in it. A recovery-oriented system of care that's person-centered, self-directed, builds on the responsibility of the individual, that individual's strengths and the resilience of not only the individual, but the individual's family and community. Communities and families are affected by alcohol and drugs. The negative consequences that reverberate from alcohol and drugs not only consume the individual, but also their family. So help is something we need to deal with. But we need to understand that we're trying to achieve recovery, wellness, and health for all three. The individual, the family, and the community. So that, in fact, we can facilitate recovery. There are many pathways to recovery. So a menu of services and supports that can be offered from the public sector point of view needs to be arrayed. Now there are other things that go into supporting a person. Peer support, natural support of the community, but from the bean counter point of view, what should the public sector pay for? What should insurers pay for? What are we concerned about? Child welfare is concerned about addiction services. We want to make sure we deal with that. Child support payments. Any of you got clients who owe more child support payment interest than they even owe in child support? I've seen that. Well, we want you to participate in recovery. Well, you know what am I going to do with this bill? Education, housing, spiritual issues, financial issues, legal issues, case management. What do you want the system to pay for? And what can the individual carry on his own? And what can the community of people in recovery help that person with? The recovery-oriented system of care focuses, from our perspective, on what it is that we should be doing and what we should be facilitating. It is not the definitive view of recovery. Because indeed, there is the instrumental approach that we can help facilitate, and then there's the social cultural support, which the community has to embrace. When we talk about recovery from cancer, we don't simply talk about what the professionals do. We talk about what the community can do, but we don't put a price tag on what the community does. But the bean counters insist that you put a price tag on what it is it pays for, the public pays for. We have many systems involved. In a recovery-oriented system of care, if we coordinate those systems, perhaps we can save a little money for the larger system. The public dollar pays for it all. My taxes pay for criminal justice, and child welfare, and housing, and education. There's only $1. Not that there's multiple dollars. We want a recovery-oriented system of care that acknowledges that there's only $1 and it's split up between all these various systems, and what we need to do is coordinate because we can save money, at least I believe, and we don't have the data yet. We need health systems data to help promote this notion. But if we can reduce the demand on the primary care system, the person who shows up in the emergency room 24 years old with chest pain, well, we're going to watch you overnight. That's $2,000. When we do cost effectiveness, when we look at our cost for our care, it's $2,000 a year per client for substance abuse treatment. It's $2,000 a night just to be hooked up to a cardiac monitor. No IVs, just $2,000. So if I can prevent that person showing up in that hospital one night, I paid for a whole year's worth of outpatient care. So the primary care system cannot say, we're not interested. Mental health system, somebody psychotic on cocaine or methamphetamine or going through DTs in observation, we've got to assign a staff person to this person full time. How much is that going to cost? That same $1, you're paying for that. Housing, social services, child welfare, to put a child in foster care. Art, how much does that cost?
A lot of money.
A lot of money. To put a child in foster care. That same $1, well, we're going to shift it from this, we're going to put it into foster care. Criminal justice system. You often heard how much it costs to incarcerate a person for a year. Back to my little anecdote. You want to help me? I mean, maybe I got insurance, they'll pay for my back and prescription drug problem that I'm going to develop from the oxycodone that I'm going to have to take for my bad back. Then you've got to incarcerate this person because after all, he's harmed me. So we need to understand if we can coordinate multiple systems, then maybe we can come up with a more efficient delivery system that will produce wellness, health, and recovery. We need to be outcomes driven. You hear about culturally appropriate strategies. I'm fond of viewing things as a black box. We've got evidence-based practices and culturally specific practices as inputs. But the question is, what happens on the other side of the inputs? Does the person get better? Do we achieve things like decreased substance use or abstinence, employment or education, a reduction in crime, social connectedness, cost effectiveness? From the government's perspective of recovery, we need to address these issues because you don't want the government involved in recovery if you define it in total. You want the government involved in aspects of recovery. Because we're here to help. And we will help you far more than you want. But if we can account for the dollar and the services that are appropriate for us in recovery, then we can assist you and we can assist the community. Many of you are professionals, some of you are advocates, others of you are in recovery. We want a cultural dynamic with give and take, but you do want to limit the role of government. You do want to limit the role of government. A recovery-oriented system care requires an ongoing process of systems improvement that incorporates the experience of those in recovery and their family members. We heard about NIATEX. It's the action campaign. We want to make sure that nobody settles into a view of, I've been doing it for 20 years and I know what I'm doing. That kind of attitude abrogates the utility of NIDA and NIAAA. It abrogates the importance of finding new ways to facilitate recovering from substance use disorders, dealing with mental health complications associated with substance use disorder. Ongoing systems improvement. We can always do things better. Maybe not today, maybe not tomorrow, maybe next week, maybe next year. But our system continues to look. And we ask the people who are directly affected by alcohol and drugs. Those are the individuals who consume and their family members who are affected and the community that's involved. So we see the recovery-oriented system of care as an important model. And from the public's point of view, the government's point of view, by focusing on the services, the systems, the outcomes, and systems improvement, we can contribute our component to the recovery process. What do you want the federal government to do? How do you want us to function in this dynamic? It is both a health issue, as health is more than just health, physical well-being. It is a social issue and a cultural issue. You don't want the government defining the cultural and the social aspects of recovery. You want us to use our resources in the most efficient and effective way to assist those people in recovery through our recovery. So we don't then define the norms. Because we're outcomes oriented. We start with what we can't define adequately, we'll define it approximately. The beauty of this discussion, the beauty of this dialogue, is that we're allowing this to be fostered and the message to be carried to the far-flung hearts of this country. So that African Americans, American Indians, gay, lesbian, bisexuals, transgender, old people, and young people can struggle with the issue of how do we deal with substance use? What do we do with mental illness? How do we achieve wellness, health, and recovery? So we are your partners. We need you to continue to think through how you're going to reach out to that 20 million people that's unmoved by the problem. The less than 400,000 who are aware and who are trying need to have access to care. But we will never be able to do an adequate job for those less than 400,000 if we don't get the voices for the 20 million heard. The recovery-oriented system of care then supports person-centered, self-directed approaches, allows the individual to decide what he or she needs to do. It also focuses on the harm caused to other people and how those other people deal with harm. That comprehensive menu of services allows the person to choose. We use our Access to Recovery initiative. We use the voucher. And some argue, well, gee, Dr. Clark, why did you do that? It's not only a strategy to involve the faith community. So the faith community has always been involved. Salvation Army, Catholic Charities, Lutheran Ministries, the founders of AA. Faith community has always been involved. This is not about the faith community. The voucher empowered the person to purchase care. As Bill pointed out, back in the day, treatment could be quite cruel. I can remember watching patients as a fellow kicked off the unit because they didn't get it. Well, did he hurt somebody? Well, no, he's just not cooperative. Did he stab somebody? No, he just doesn't get it. Well, what are we going to do with this guy? Well, we're going to kick him out. Can he come back? Yes, when he gets it. But why would he come back if he gets it? I mean, those were the attitudes. As I was talking to George, though, those attitudes were allowed to develop. And they developed, unfortunately or fortunately, in a benign way, although they had non-benign impact. Why? Because nobody else wanted to deal with alcohol and drugs. So we have a whole lot of mythology, because people were desperate for solutions. So we want to use what NIAAA, NIDA, NIMH bring to the calculus. So in fact, we don't have people desperate for solutions and therefore winging it. Well, this seems to work for me, so we're going to do this for everybody, regardless of what the person needs. We want community-based, a commitment to peer services, and we've tried to foster that. And we really favor people bringing that voice so we can get that 20 million people who say, okay, this is an issue. Talk about medication-assisted treatment. Okay, it works. Tom points out and others, gee, we don't talk about the diabetic who needs medication, the asthmatic who needs medication, the person with hypertension who needs medication. We don't say their lives are less worthy. We need to make sure that we foster a welcoming community. Family, other allies, I'm fond of saying the family's the last to let you go and the last to take you back. They have been hurt. The person who has hurt his or her family will find that they've been burnt and they have a reaction to that. And I don't care what professional wants to have a family night. Let's have a family night and talk about it. Well, let me tell you, look, here's the list. This is only half the list because I didn't start keeping it until the bank account was cleared out. And ongoing monitoring and outreach, I agree. When the government has to be involved, we need to have an outcomes-oriented component. So those things that we facilitate have got to be able to demonstrate their utility. We prefer integrated services, competency-based. We prefer the effective use of collaboration, non-duplication. Criminal justice can save money by partnering with public health. Public health can save money by making sure that child welfare is actively involved. Child welfare can save money making sure education is involved. We need systemized education and training, continuity of care, and what we do should be research-based and flexibly funded. This is our draft. It's not static. It's not cast in granite. It's part of the ongoing dynamic that we need to be involved in. My hope personally is that when the next administration comes, we take this draft, we flesh it out, we allow the administration to say, yeah, people have been thinking about what they need to do. And if those other voices have had an impact, we'll have a willingness on the part of the politicals to address the issues that we're discussing here today. We've made a lot of progress. We've come a long way. We can move beyond anecdote and impression and personal view to manualize treatment strategies and a community that supports everyone. A place in the community for everyone. So that we can continue to contribute to build resilience and facilitate recovery as a partner to the community, not as the entity that defines for the community the cultural and social aspects of recovery. That becomes very important. You are very important, and ultimately, you will help us sell treatment to those who need it and help facilitate the support from the community by those who are affected by those who need treatment. But I want to end on the theme that there are many pathways to recovery. Many pathways to recovery from many diseases. My mother is diabetic. She's 90 years old this year, as she tells me. And she fastidiously tests her blood sugar in the morning, but she doesn't need oral hypoglycemics and she doesn't need insulin. But every morning, she tests her blood sugar. She watches her diet. Better than I do. And it talks to him periodically. And we don't expect anybody's going to pay for those things. But what you've got is a community that says, and a family that says, you're one of us, something has occurred, and we will support you regardless of that. And that's what recovery means to me, even if we can't change the outcome. My brother gets support, my mother focuses on doing what the doctor asks. But the community embraces. So the social and cultural aspects of recovery are critical. The community defines that. The integrated services, the services part of recovery are critical. It is not inappropriate for us to ask the insurance companies to play a role, the employers to play a role, the unions to play a role, employees to play a role, and the government to play a role. We need all of the voices on the same page. So I thank you.